Principles of medication administration. So in order to give your drugs, you've got to be able to do a couple of different things. So one of the things you want to be able to do is calculate your drug dosages. We'll talk about that in a separate video. We have to be able to find the correct medication, select the correct one. We have to be able to prepare the medication. Some medication comes already pre-prepared, like a pre-filled syringe or something like that, but not all of them do. Occasionally, drugs will require reconstituting, so you've got to make sure that you know the correct preparation there. And you've got to adhere to your principles of safe administration. The key here, when you're giving drugs, you can always give more drug, but you can't ever take it back once you give it. So it's absolutely vital that you pay very close attention to what you are doing. So before you give a med, you've got to also have some knowledge. You've got to know the anatomy, the physiology. For instance, if you're giving something in the deltoid, well, you have to know where what the deltoid is and where it's located. You also need to understand the pathophysiology of why you're giving a drug. You know, a lot of paramedics are real bad to, we'll go give them some fluids, we're going to put some fluids in them, but they don't know why. Fluids are drugs. Normal saline is a drug. Lactated Ringer's is a drug. D5W is a drug. And if you're going to give a drug, you need to know why that you are giving it and what you can expect to happen as well. You also need to understand the actual pharmacology of the drug itself. What's going to happen with that drug? How is it going to work? What is it going to do? At least to the best that you can. Then you also have to have some skills: history taking, assessment, clinical reasoning, and critical thinking. If you aren't able to take an adequate history, you won't know your indications for giving a drug. If you are not able to do a thorough assessment, you won't be able to find your indications for giving a drug. What do you think are the most common types of medication administration errors that result in death? If you said wrong dose, you would be absolutely correct. Now, before you give a medication, there's a couple of different things that you absolutely must know about that drug. And this information makes up the drug profile. So this is going to be the medication name. It seems simple, right? The name of the medication, but it's what you have to give. It's the name that you're going to be looking for. You need to be familiar with your trade names and your generic names, because sometimes people will use them interchangeably. Ondansetron versus Zofran, for instance. Classification. There are different classifications that you can use, and some drugs may fall in multiple classifications, but overall this is just a broad grouping of what this medication will do, like antiemetics or something, that are things that are going to help you not vomit. Your mechanism of action is how the drug is going to work in the body. Your indications, of course, are why you would give a drug. Your pharmacokinetics are how the drug is absorbed, distributed in the tissues, and eliminated from the body. Remember, we talked about that more in another video. And then the side effects of the drug. What can we expect to happen perhaps with this drug administration? We need to make sure that we know the routes of administration, because there's a very big difference between something given IV, PO, PR, transcutaneous, a lot of different routes there. We have to know our contraindications. When to not give this drug is just as important as when to give this drug. We have to know the appropriate dose. Sometimes there are multiple doses based on weight, or based on age, or based on other bodily functions like liver failure, kidney failure, things like that. You also need to know how this drug is supplied, because in order to calculate appropriate dosages, you've got to be able to look at that container and figure out the concentration, how much drug is in that container, whether it be in liquid, powder, format, pill, tablet, whatever. And then any special considerations. So I like to use nitroglycerin as a good example as far as like your side effects and things like that. Mechanism of action. What is the mechanism of action of nitro? Alright, so nitroglycerin is a vasodilator, and it's actually going to cause peripheral vasodilation and a little bit of coronary vasodilation, but most of peripheral vasodilation, which is going to decrease preload come into the heart. When we decrease preload come into the heart, we decrease the workload of the heart. We decrease the workload of the heart, we decrease the oxygen demand of the heart. So it kind of works in a roundabout kind of a way. Now your indications. Well, our indications are chest pain, right? Angina, suggestive of potential MI. We already talked a little bit about the pharmacokinetics there, but your side effects. What are the side effects of nitro? Well, we know one of the big ones is a potential for a headache. All right. Another potential side effect, which would also be considered an untoward or detrimental effect, would be a drop in blood pressure or hypotension. Now, our routes of administration. It can be given as a sublingual spray. as a dissolving sublingual tablet, and it can also be given as a paste. And it just depends on which type of nitro you have, because we give it as a drip. In the pre-hospital setting as an advanced, typically you will have either this dissolving tablet or you will have the spray. Your contraindications. Hypotension. Some books say 100 over systolic, some say 90 systolic, but generally about 100 systolic blood pressure. Anything below that, you really don't want to use your nitro because of that potential drop in your blood pressure there. You also don't want to use it in a known right-sided MI, because when you decrease your preload in a right-sided MI, you lose your cardiac output. It drops down drastically. You also don't want to give nitro if they've had any kind of erectile dysfunction medications taken within the past about 48 hours. So real important to know all these different key there's. The dose. The dose of nitro is 0.4 milligrams per spray, per tablet, or usually per inch of paste. Right, how the drug is supplied? Well, it depends on where you work. Some may have the paste, some may have the tablet, some may have the spray. Some places may be able to do a nitro drip. And then any special considerations, like say if they've got known cardiac history, extensive cardiac history, then nitro may or may not be appropriate. You never know. Now, for your principles of safe medication administration, of course, the 6 rights. Everybody knows the 5 rights, so we're going to add one more, make it the 6 rights. So we've got the right patient, which of course is usually going to be fairly easy for us because it's the right patient. We've only got one. But more importantly, does this medication fit for this patient? So does this patient meet the criteria or the qualifications for giving this particular medication for us at this point in time in the pre-hospital setting? Then we're looking at the right medication. Is this the right medication? Have they changed the packaging? So make sure that you're getting the right, actually physically putting your hands on the right drug itself. Then we're going to make sure we've got the right dose. There's lots of different places we can check, PDRs, lots of references, apps, things like that. But protocols as well usually will detail out exactly what dose you're allowed to give in this particular area. And then your right route, of course, making sure, if it's an IV drug, we don't want to give it orally. If it's an oral drug, we don't want to give it IV or IO. So make sure you're giving it the right route. The right time. Is now the right time? Is it the right timing? All these things that we're looking for here. Then, right documentation. That's the new one that we're going to add here. And right documentation is really important because you need to document the rights in your documentation to protect yourself. If you're not, then you're leaving yourself up for questioning and potentially some negligence if you can't prove how much, how, when, why. And also you want to document the results. Sometimes medications don't work for the patients. Sometimes they do. Sometimes patients have a negative side effect, and that's okay. The important thing is that you recognize it, address it, document it, and treat it, and go on from there. That reassessment is really key. Now, as far as medication safety, medication errors kill a lot of patients needlessly every single year. And it's not just at the EMT, advanced EMT, paramedic, pre-hospital level. We're talking nurses, we're talking doctors, we're talking surgeons and anesthesiologists. We're talking across the board. Medication errors kill patients, and it shouldn't. Right, so some things we want to think about. Your packaging, your labeling, your storing, dispensing, administering, these are all places where errors can occur. So we want to make sure that we are making sure that we have the right medication. Lidocaine, for instance, comes in a lot of different concentrations. So it would be very easy to overdose a patient on lidocaine if you got, say, like a localized numbing concentration versus one that's meant to be given intravenously. So you really want to make sure that you're using the right concentration. Now a lot of your lidocaine is pre-mixed, or it's mixed in like a hospital pharmacy or something like that, instead of having a healthcare provider, dilute it or draw up the proper amount to make the proper percentages. I've noticed a lot where we have medication shortages, and substitutions are happening a lot. In just recent years, I know I've made my own D50 essentially. We've had alternating orally dissolving tablets for Zofran and also your IV intravenous Zofran. It just all depends on what the agencies can get at that particular time when they're ordering drugs. A lot of companies are going out of business that are making like these pre-filled syringes, and so maybe one drug used to come in a purple box, and now that the company that was primarily making them shut down, so they're having to go to a different one. So maybe it's not the pre-filled syringe anymore. Maybe it's in a vial and you have to draw it up. or maybe the color of the box has changed or something like that. So it's real important that you look at it and make sure that what drug you're getting is the right drug. Don't just go on, oh, it's always been in the purple box, so we're going to get the purple box. Look at that drug and make sure that it's the same concentration, the correct dose, and the correct route that you're supposed to be using. Also make sure that the concentration hasn't changed. Maybe ketamine is a pretty good example. Some ketamine, I've seen ketamine come in like smaller, I believe it was 20 milligram or 25 milligram bottle vials, like basically a single dose. And then I've also seen ketamine come in 500 milligram dose vials. That's a substantial difference in amount there. So make sure that you know what concentration and dosing is coming from this medication that you're getting. When you open a box, never assume that the box matches the vial inside. Should it? Absolutely. Don't assume it though, okay? Open the box, look at the label on the drug. Now, we can't do anything about the drug inside the vial or the container. That is what it is. But we can make sure, because errors happen. Machines make mistakes, people make mistakes. Make sure that you look inside that box, make sure that you see what that vial says that it is. As far as labeling, when you are mixing drugs, make sure that you label them appropriately. Date, time, what the concentration is, what drug it is, your initials. That's just some of the information that needs to be put on that label there. As far as storing your drugs, some drugs, a lot of drugs, are heat and cold sensitive. So nitro, for example, is heat sensitive, which is why a lot of times it won't work if they've kept it in their pocket on their body for long periods of time. Extreme heat, extreme cold can ruin or change how the drug works or make it non-effective, which is bad for us because usually the drugs that we're giving are life-saving. So make sure, I live here in Alabama and it gets hot. It gets stupid hot in the summertime and the humidity's 100%. You walk outside and it's like somebody dumps a bottle of water on you. It's so steamy outside. Inside the ambulance, it gets even hotter. Even with the air conditioner running, it is still extraordinarily hot in the middle of the day in July and August and September and June and pretty much the whole summer. I bring my drugs in. I bring my drugs in with me and I hook the keys to the ambulance on the drug box, so we literally cannot go anywhere without them. If we're going to the station or something, we're not on a run, I take them inside with me. Same thing in the very cold. I also bring some bags of fluid in when it's very cold, because what happens is, let's say if it's 50, 60 degrees outside, right? 60 degrees outside probably, to me, feels pretty good. Doesn't feel all that cold. But if it's 60 degrees outside, your fluids that are sitting on your shelf, if your ambulance is not running, is going to be 60 degrees on the shelf as well. Well, what happens when you go start an IV on somebody at 2 o'clock in the morning and it's nice and chilly and you're half asleep and you start that bag and you start running it, and then, oh, your patient doesn't look so good anymore. If you put 60 degree fluid in somebody, what's going to happen? You're going to put them in hypothermia. So make sure that you are taking care of your drugs. It's like a tool. You got to take care of them just like you would anything else. When you're going to dispense a drug, when you're going to administer a drug, make sure that you are double checking. We teach our students to double check your medications, and you always should double check your medications. I've double checked medications with patients if I didn't have anybody there to double check with me. I'm giving this drug, this is what this drug is, I'm giving this much. To give this much drug, I'm drawing up this much. Will you verify? Have that patient verify. Have your partner verify. Errors happen. That's why people die. So take that few extra seconds and double check yourself. I personally will triple check myself. I'll double check myself, then I'll have somebody else check it, and then I'll still double check. And every time I'm checking, I'm asking that patient, no allergies, right? No allergies? Have you ever had this? Are you allergic to this? I'm making sure I'm giving them every opportunity to make sure I don't make an error. Now, your routes of administration, we've got two primary routes, and you've got enteral and parenteral. So your enteral routes are going to access through the vasculature of the GI system, usually in the small intestines. These can be liquid, solid, or semi-solids. So if it's by mouth, it would be PO, and if it's parectal, then it would be PR. Now, some books will say, or will consider buccal and sublingual as enteral routes as well, but it just depends on what the book says. But they are not true enteral routes because they are not absorbed through the vasculature of the GI system, just like the parectal. They're actually absorbed in the vessels surrounding their entrance points. Now, your parenteral routes are everything else. So these bypass the GI tract. So these are liquid, gas, Semisolids, these are in your inhalations, your sublinguals, your subcutaneous, your IM, your intravenous, infusions and bolus there, and your intraosseous. So these are all different forms of your parenteral routes. Now, when you're looking at parenteral routes that are your routes in general, the time of onset of action depends on the length of time it takes the medication to get into circulation. So your sub-Q is usually going to be about this, and your sub-Q is going to be the slowest because in order for it to get into the system, it has to be absorbed in through the peripheral vasculature and absorbed through the subdermal layers and then go into circulation. Your IM is a little bit faster. It's going into your large skeletal muscle groups, and this is going to have a larger vascular system, so it's going to absorb just a little bit faster than your sub-Q. Still going to be slower than your IV or your IO. IV is a little bit faster than your IO, but they're both really, really fast. So anything that goes into your IV goes directly into your venous system. So it's really important here that you make sure that you're getting the right dosages, because you're going straight in and it goes back to the heart and then disperses throughout the body. This is really fast because there's no breakdown. It doesn't have to be absorbed in. It doesn't have to go to the liver and get broken down. It's just there and it's available and it's ready to go. The IO is essentially the same, but instead of going straight into the vasculature, it goes into the medullary cavity of a bone, which then absorbs through its vasculature, which is also very, very rapid. Now your drugs for inhalation are going to be your gases, and these are going to be your aerosolized liquids or powders, and they are absorbed very rapidly across the respiratory membrane, but the problem with them is that they have to be very fine particulates, and if they aren't, they're not going to easily transfer across that respiratory membrane there, which is why not a lot of drugs are eligible for a inhalation route. Now, when we're talking drug orders, you only give drugs on the order of a licensed physician that's providing your EMS medical direction. So like Joe Blow, doctor that stops on the side of the road is like, give him this and give him that. Can't do it unless he's your medical director that happened to stop by. He can't give you your orders there. Now, of course, going back to some of the stuff we talked about with the legal, different types of orders. You've got standing orders, written orders, and verbal orders. Standing orders are going to be like your protocols. Right? These are going to be the ones that are always there. You know what to do. You've got, if this happens, then you do this. If this happens, then you do this. Your written orders are going to be something that would be like if you work at an ER or clinic setting or something like that. And this is where they're actually going to physically either type up or write out the orders, and then you would follow through or carry out those orders. And then verbal orders, which is going to be the other more common pre-hospital setting order type, is where you call in for reports. So you call in, give the doctor your information, and then get permission or orders for certain procedures or drugs from there. Whenever you get an order, make sure that you repeat back word for word to make sure that you understand the order correctly. And then make sure that you document all of your pertinent information, how you carried out that order, any complications, and the response to the medication. Now, if you get an order that you think is wrong, if you think it's an error, request further clarification. Do not carry out a medication order that you know is dangerous or that you know is an error. All right, it's our job to be that patient advocate. When we are interpreting these orders, we want to make sure that we are including the drug name so that there's no confusion there. The concentration, if applicable, say for advanced, that would be like epi 1 to 1,000. If the doctor says give them 1 to 10,000, well, we can't give 1 to 10,000. We give 1 to 1,000, and we only give it IM. We want to make sure that we have the proper dosage. If the doctor tells you give 1 milligram of epi 1 to 1,000 IV, time out. We can do IVs. We can give epi to 1 to 1,000, but those two don't match. We cannot give epi 1 to 1,000 IV. We have to do it IM, and we don't give 1 milligram. All right, make sure you got the right route of administration and the rate of frequency of repetition if applicable. Use standard abbreviations when you're documenting. Right, BS could be BS or it could be breath sounds. There's a lot of different interpretations. Make sure that you're only using standard approved abbreviations. When documenting, make sure, or calculating, writing out any drug dosages, make sure if it's less than 1 unit, you always use a leading zero. So it would be 0.4 milligrams. And conversely, if you're using a whole number, do not put a decimal and a zero at the end. So if it's 25 grams, it's not 25.0 grams because those points tend to disappear, and then you can end up with a drastically different dose and dead patients. So before we give a medication, we want to make sure that we've done a good history and a good assessment to make sure the medication is indicated and there are no contraindications or complications. We want to ask about any medications the patient currently takes because there are some over-the-counter medications that can affect medications that we may give. When I ask about drug allergies, I will ask them 3 or 4 times about their allergies to make sure, absolutely sure, that they have given me every opportunity to tell me. And then you want to make sure that you ask about conditions that would contraindicate a particular drug. Like for nitro, we mentioned earlier, erectile dysfunction drugs. It's not fun to ask them, hey, do you take Viagra or Cialis? But you have to find out if you're going to give them nitro. And don't just not ask the ladies, because some women will take it as well. So make sure you ask everybody that you give nitro to, have you taken an erectile dysfunction medication in the past 48 hours before you give this drug? And make sure they understand, because it could kill you. I'm not just being nosy. We need to know because we don't want to harm you. Make sure you get a complete baseline set of vitals. Alright, sometimes to include blood glucose as applicable. Make sure that we are documenting the procedure, that we reassess our patient, and document any findings. Remember that patients will have changes, patients will get worse, patients will get better. Sometimes it's because of the medication we gave, sometimes it's not, but it's okay for the patient to have side effects as long as you document, and you're documenting your reassessment, and that you are working to try to improve it or fix it, whatever you've done for them. After giving medications, you must reassess the patient, document your findings, ask the patient if they've experienced a change in the original symptoms or developed any new symptoms. Basically, I tell them, tell me if anything changes, better, worse, or different. And then make sure that you're comparing any subsequent vital signs to your baseline values. And reassess, reassess, reassess.